Hi guys. Let's get started because you're all here and that way we'll get finished quicker. That's always a good thing, right? Okay, I brought you a handout for some of the slides that I'm going to talk about and put it in a format so that you can make notes as we go. Some of this stuff I'm going to cover is going to be review for you. And then I promise some of it's going to be stuff that you probably haven't heard before. My name is SIM-Sislak. I graduated from Texas Women's University in nursing, and I worked in ICU. So all my experience is in ICU. And I did go to ICU right from the get-go. So that means TWU prepared me to. I did very well there, which means, again, that TWU prepared me for that. But I was a second degree, which I know the weekend program, there's a lot of you as well that may be working on a second degree. My first degree was in computer engineering from Alabama. Roll Tide. Sorry. But I think that it helps in ICU if you have kind of a background that's a bit more technical, because so much of what we do in ICU is related to machines and equipment and technical. So people say that those fields are totally opposite, but I didn't find them to be so opposite. And certainly, as I've taken the job as nursing lab administrator here at Texas Women's University, and I oversee the simulation lab, those two degrees work really, really well together, as they would in education as well in nursing, because we have to use mannequins. We don't have a choice, because we can't let students, if something goes wrong at the hospital, we can't stand back and let you try. We have to push you out of the way. You'll be lucky if you get to observe what goes on. But in simulation with a mannequin, we can allow you to try, or setting up a simulation and saying, hey, what would you do in this? We can stand back and let you give it a go. So I think that the two work real well together. So if you're planning on going in ICU, plan on having to have at least some technical background, and if you're not strong in it, just plan on it being something that you're going to have to work on. Okay? So I'm going to go over a whole bunch of different equipment that you're apt to see in ICU, lines and what they do. And like I said, a lot of it will be stuff that you've already heard and it's going to be review. And then others will be new stuff that you probably haven't heard, because some of the stuff gets more technical. I call it mind your lines, because the lines are difficult. How many of you have done a rotation in ICU? Anybody yet? Okay, either way, doesn't matter. Did you, when you walked in, did it feel like it might be just a little overwhelming because you weren't exactly sure even what all the lines were? No, you felt pretty calm? Oh, well, good. Well, maybe this will just be review for you. We'll see. Notes and warnings, I don't have to do this for you guys. Sometimes I do this lecture with other groups that are not as healthcare oriented, so this one might not be. These are your objectives, very important. Identify the different cords, lines, drains that are connected to a patient. May or may not be something that you've seen. There's a lot that you'll see in ICU that you will not see on a floor. That just it is, because the higher the acuity, the more stuff that they have connected. The second thing is you should be able to identify which ones have critical consequences, because as a nurse, you need to be wary of the ones that would have critical consequences and not sweat the small stuff, because it is overwhelming. And I promise you there's not any ICU nurse alive that hasn't told you or won't tell you that there are shifts in the middle of the shift when you feel that feeling of panic creeping up in your chest and having to push down that panic, that don't have a sense of being overwhelmed. Every ICU nurse feels that at some point in their shift, and they have to have coping skills for how to manage it. So being able to prioritize on the fly and as fast as possible, and also trying to focus on one task at a time, the highest priority, even though so much is going on around you. So that can be challenging as well. So let's go over some of the things that you might see in ICU so that you can be better prepared when you do your ICU rotation or you go into an ICU room. And maybe I'll tell you some funny stories along the way. So we're going to start at the top. It's going to be really easy. I wanted to go in order of what airway systems we use, air delivery system, oxygen delivery systems, starting from the very minimum up to what's the worst. Because that should tell you something about the acuity of your patient, right? The higher level of oxygen delivery, the more serious the patient is. That makes perfect sense, and you guys already know that. I love this picture. She doesn't even look like she needs a nasal cannula, does she? So she looks perfectly okay. So what is the proper range for the amount of oxygen if they have a nasal cannula? So what's safe, what's not safe? 2 to 6. You guys are sharp. So is this a patient that is going to be the highest on your acuity in an ICU? I assure you it's not. This is the first step. This is a patient that, and why do all ICU nurses want to put every patient on a nasal cannula? Have you ever noticed that? Everybody's on a nasal cannula. Why? It's like Murphy's Law. We're like, if we get the oxygen delivery system there, they won't need it. We assume that anyone that's coming into ICU obviously is there for a reason. So we want to make sure that things are set to where if something goes bad, which often does in ICU, we're set, we're ready to go. We already know there's a Christmas tree. We already know, everyone know what a Christmas tree is? Ah, she does. What's a Christmas tree? Because they're not always available when you need them. It's that little Christmas tree that screws on to the oxygen meter that comes out of the wall. Not every room necessarily has them. So we like to connect a nasal cannula just because we know we're set to go, no matter what. So oftentimes you'll see even the smiling lady that probably doesn't need a nasal cannula, we still have it on. I think that part of the time we do it more than we probably should, but it wards off, Murphy's Law. If we have it, we won't need it. The only thing you have to be aware with this is you should know whether the patient can go temporarily without it in ICU. Like, does this patient need it even if they get up to go to the bathroom, right? Or is it something that I could turn off temporarily to get them up to the bathroom and then put it back on when they get in bed? Because just because it's on doesn't mean it has to be on. And moving with oxygen tubing a patient is dangerous. You automatically will increase the chances of a person falling by every line you have to move with the patient. So you should always know or be aware of which ones can maybe be turned off and which ones can't. Like, can they come off the monitor just to go to the bathroom? The answer is there's no set one-way answer. It depends on the patient. So the lady decompensated on her oxygen saturation, and now we have to step it up a layer. The next level up from nasal cannula is a simple mask. What's the rate for the mask? Yeah, 10, 12, somewhere in there is about right. Okay, and that's important because when you walk into a room, if you see an oxygen delivery device, you kind of should look at the oxygen amount. Is it right? Did someone set it right? Did it get knocked? When you're doing your initial assessment of your environment in ICU, you kind of need to check. How long do you think we can leave them on a face mask? Leave them on. Do you think this is something we can just leave them on days on end? No. And why? We don't leave them on a face mask. Generally, we don't. Usually, if they can't be on a nasal cannula, they're going to be, it's because they need more oxygen. We do not leave patients indefinitely, even for hours, on a face mask because it distorts the oxygen levels as opposed to the carbon dioxide exhaled. So what we do is put them on a non-rebreather. A non-rebreather is safer to not mess up those oxygen to carbon dioxide levels. So a partial non-rebreather mask is probably a better choice, but this is a good temporary. Especially if it's like they just all of a sudden can't breathe and that's what you have, you're slapping on them. Then when you find something and by the way, what does the partial non-rebreather deliver? What's the rate of it, the next step up? You can go all the way up on it. One's with the bag, the inflated bag, and it provides safer on the level, so we can leave them hours on a non-rebreather mask. Let's go to the next one. You can leave them for long, long periods of time on this. This we're not as worried about. That doesn't mean they can stay indefinitely, though. In ICU, we still won't leave them indefinitely on this. This is turned all the way up. This isn't a good choice either. So what's the next step that we can go? We've gone over 2. Now, if you see them on a face mask or a non-rebreather mask, do you think you can get them up to go to the bathroom without the mask? The answer is no. You should know right away that that means there's some reason that they're needing the oxygen, the increased amount of oxygen. So we're not going to be able to take this off even to get up to go to the bathroom. So now I have another question, critical thinking question. Are you ever in ICU going to see a patient on both a nasal cannula and a non-rebreather mask? And can you think of any reason why in any hospital you would see them have both? Do we ever do that? We do. And I'll tell you what it relates to. What about the patient that it's something to do with activities of daily living, that they are tanking so quickly when I remove the mask? So, mouth care, eating, that's an excellent choice. Mouth care, eating. If I have a patient who's tanking on SpO2, every time I move the mask, just temporarily to take even a bite of food, right? I might put a nasal cannula in so that when I'm doing this, they're getting some oxygen and they won't tank as fast. So we do both occasionally. It depends on the status of the patient. And because, let's face it, some of our COPDers, you know, they're struggling. And it's harder to recover the lower they go. It takes longer for them to recover and come back up to something that's okay. So we're going to try to keep them from tanking as fast. And we don't want to keep them from eating. I mean, they can't not eat indefinitely. So there may be a time that you will have a patient on both. In fact, as they're recovering, lungs are starting to recover, we often will do it because we know if they have some lung process going on, pneumonia or ARDS, we know that in time, it's getting better and better as we go. We're going to finally get to a point where we won't need the mask and they'll be on just the nasal cannula. And well, look, you already have it. This is a Veni mask, and I got to be honest with you, I've never seen one in ICU. I think this is more often seen in the home environment. I wanted you to be aware of it just because it's something that you could possibly see, and it is an oxygen delivery device. But the Veni mask actually has a little knob on the actual mask itself that sets how much oxygen concentration is being delivered. So we don't mess. All you should know is you're not going to adjust the knobs unless the patient starts to tank and you need to, and that's what it's there for. But I've not even seen one. I'm not even sure they use them on the floor. I think they're more often used in a home environment, and possibly because it might be safer to not have the knob turned, right, in the home environment. CPAP and BiPAP. So here's your question. What does CPAP stand for? Continuous positive airway pressure. And what is BiPAP? It's bi-level positive airway pressure. So the difference between CPAP, as you all know, I'm sure, is something that we prescribe or they prescribe for sleep apnea to allow that positive pressure in the lungs. Okay? BiPAP it's the same machine. In fact, most machines can do both. At the hospital they can. That's not necessarily true in the home environment. But in the hospital, a ventilator that you see even on intubated patients can be a CPAP, a BiPAP, or an actual ventilator for an intubated patient. So we can set it. It's just the setting on the ventilator itself that allows us to set for which we want. The next step up, you did the nasal cannula, patient tanked. You did the simple mask, patient still tanked, and besides that, we can't leave a simple mask on indefinitely. So I moved them to a non-rebreather. Next step up, they're still having trouble. Next step is a BiPAP. Fits very tightly around the mouth and nose. No air gets in around it. We want it to be as tight as possible to prevent air from getting in around. Why? I get asked this question all the time by nursing students. Why are we trying to prevent air from getting into a patient's lungs? That doesn't seem to make any sense whatsoever. The concentrated, we're trying to prevent. So let's talk about room air as opposed to what a ventilator or a BiPAP machine can deliver. FiO2 of room air is 21% oxygen. I just inhaled 21% oxygen. A normal healthy person only uses somewhere between 8 and 12% of oxygen with each breath. We don't need the rest, which is why we're able to, right, when we're saving someone's life. Because our exhale, still has enough oxygen in it for that patient to get oxygen, even on our exhale. However, a ventilator, BiPAP, CPAP, can deliver far greater than 21%. We can go all the way up to 100% concentration on oxygen. So our goal when we get to the point of BiPAP is to seal room air, which is low 21% oxygen concentration, and deliver as much as we need to deliver to keep the patient at a safe level or a stable level, if that makes sense. It's not tight enough. And yeah, it's a great question. The non-rebreather is just a mask with an exhale bag to better, try to figure out a good way to say it, to better keep the levels of carbon dioxide and oxygen to be safe. But it doesn't seal. I will tell you that patients that we first put on a BiPAP that have not slept with a CPAP, now you love the patients that have slept with a CPAP because they don't mind that tight-fitting mask around their nose and mouth. Doesn't bother them a bit. They're like, puts me right to sleep. But a patient that does not have a CPAP at home will get very claustrophobic when we first put a BiPAP on them. And it can be quite challenging to get them to not want to pull that mask off their face because it fits fairly tightly around the mouth and nose. It's very snug, and it can almost be like a claustrophobic. So part of your job as an ICU nurse is to say, you got to leave the mask, you got to leave the mask. Because if they can't leave the mask because they're, and think about it, you're struggling to breathe, and I put something tight-fitting around your mouth and nose. What is your first reaction? You're still struggling to breathe. What are you going to do? Get something out from under. I need to clear the way. I can't breathe. So you have to fight against or help them fight against that urge to remove that tight-fitting mask from around their mouth and nose. Because if you can't successfully get them to keep it on, what's the next step? Intubation. Is a patient, and so if you see a patient with a tight-fitting mask around their mouth and nose in ICU, is that a person who can get up to go to the bathroom without the oxygen? I don't know, because I don't know if the machine is set to CPAP or BiPAP. I have to go look. What if they're just using it for sleep apnea? So the answer is, there isn't a conclusive answer. But you are correct that generally speaking, we have to assume in ICU that if they are connected to any kind of a BiPAP machine, we have to assume that there's a reason for it. Safer. So that doesn't work. They can't leave it on, or it's still not, they're still tanking. Next step, we intubate. So I'll tell you a funny story. Got to keep it light. So Harris Hospital is where I did ICU. We have 5 ICUs. We had a patient come in on New Year's Eve. She was found unresponsive, not awake, but in the ER, they were afraid that she may have fallen and had a head injury because she finally woke up in the ER, but she was combative. She was nonverbal. She was making all kinds of sounds, none of which made sense, and she was slinging fists, even though we were trying to assure her we needed to do a CT. We need to make sure she doesn't have a head injury. She could have fallen and had a head injury. Nope, still combative. Do you know what happens when that happens? We're going to get a CT. We have to assume that you're having a medical issue that is causing you to not be responsive or able to respond. And we need to rule out for your own safety. So you just bought yourself a tube. We're going to propofol Everyone know what propofol is? Michael Jackson milk's what they used to call it. That white lipids that hang. We're going to propofol you, we're going to put a tube in, and we're going to send you to CT. We're going to find out whether or not you have a head injury. It's for your safety. Well, lo and behold, she has a tube in. We go to CT. CT comes back clear. Blood alcohol level comes back sky high, which you probably could have guessed. When we're extubating somebody, I know this sounds terrible. Do you think it's pleasant to be awake and intubated? No. We keep the propofol on to keep you knocked out. And we do that because that tube is laying across your gag reflex. You're going to be doing like that the whole time. It sits all the way down across that gag reflex. So, here's the bad news. Yes, we will intubate you. And yes, we will put you out to do it. But when we wake you up, we have to wake you up before we can get the tube out. Because we have to make sure that you're able to wake up. I at least have to find out, are you aware enough to give me a sign that you're cognitive enough to be awake enough that the propofol has worn off enough to where it's safe to wake you up. So being intubated isn't fun because of that. Because for about 20 or 30 minutes, you're going to be partly awake and remember it and have that tube across your gag reflex. It's not pleasant. So this girl, once we saw the blood alcohol, she bought herself a 24-hour stay in ICU. We finally decided the next morning that she might be sober enough to wean off the propofol, try to wake her up. So the doctors are there, and the RT is there, and the nurses are there. We're all there, and we had the propofol turned off. She became combative and non-responsive, and I'm yelling, "Show me 2 fingers. I need you to show me 2 fingers right this minute." Oh, she showed me 2 fingers all right, one on each hand. We all laughed and removed the tube. You can't be thin-skinned. You have to understand that I'm sure it wasn't pleasant having that thing across her gag reflex. So she was definitely conscious, and that's why we laughed. Oh, let me go back to that. Let me go back to that ET tube. When you have an intubated patient, what are some of the things that you need to be aware of? What goes with someone that's on a vent? Intubated, vented patient. What are some of the things you have to do every 2 hours? Anybody have any guesses? Suction is good. That's excellent because sometimes when they have some kind of an infection, they're producing copious amounts of all kinds of drainage. So suction is a good thing to do every 2 hours or as needed. It can be more. I've done patients that produced I was in there like every hour, like, and by the way, no nurses like that sound. I'm just going to warn you, none of us do. No one likes the sound of, nobody. You walk by and go, ugh, but you still do it. Mouth care. What about mouth care? Every 2 hours on an intubated patient. Other things you need to do. They are literally propofoled out. They can't move. That means we have to move them every 2 hours. Left, flat, right, have to be moved. Those are some of the basic requirements for an intubated patient, in addition to monitoring, of course, their oxygenation status, right? And that's pretty much constant because we need to know whether you turn it up or turn it down. So let me ask you another critical thinking question. If a vent needs changed because the patient's not doing well, say at 60% FiO2, are you authorized as a nurse to change it? Yes. It is absolutely 100% within the scope of your practice with your nursing license to change it. Most hospitals have a protocol to call RT, and so they want RT to document and be there to do changes. But in ICU, you might call at 2 a.m. and the RT says, "I'm tied up in ER. I can't get over there." Well, my patient can't wait. I can't wait an hour. I need to up it. You've notified them, and there's allowances for that. but I wanted you to know that it is absolutely within the scope of your practice to do so. You do need to check with your hospital on what your protocol is on your particular ICU unit. Let's go over trachs. We have two different types of trachs. We have the tracheostomy that's the permanent person that's going to live with a trach their whole life, right? From the time they have it till they're no longer here. We also have temporary tracheostomies. This can happen in a couple different ways. This can happen from an emergency where they weren't able to breathe or they were choking and they had no choice but to go below it. Or it can also happen, and I'm going to tell you, you'll see this the most often in ICU. We have one particular disease process that makes it difficult to do any kind of surgery because of the anesthesia impact to the patient. This one particular disease process, it makes it difficult to get off the vent after surgery, after we intubate. Can anyone guess what that diagnosis might be? One that's going to be very difficult to get off and to take the tube out, because they're just not going to maintain SpO2 well enough to where we feel comfortable pulling that tube. I'll give you another hint. It's also the same diagnosis, and the reason that it's hard to get them off a tube and a vent is because their drive to breathe has been changed by their disease process. Very good. Excellent. You guys are so sharp. COPD. Their drive to take a breath, what actually drives their breathing, has actually changed to be in a deprivation of oxygen. Their oxygen is too low, so they take a breath. That's not how normal people's drive to breathe works. We actually have a buildup of CO2, and that buildup of CO2 causes us to know, oh, I need to take a breath. They have lived so long with COPD, their actual body drive that says when it's time to take a breath has been changed. Can you imagine if now it's deprivation of oxygen is what causes them to take a breath, and you just intubated them for surgery on a FiO2 at 60, 70, 80% oxygen? So what has happened? They quit breathing. You're like, uh-oh, they're not coming back because they quit breathing, which is why you'll always hear before surgery, do you have a history of smoking? How much do you smoke? They're always trying to ascertain, are you COPD? Because they know there's going to be a problem. But here's what we find in ICU. If we have those COPDers, and you'll see a lot of them in ICU, if they have to do a surgery and we're having trouble getting them off the vent, we can easily, not easily, but we can send them out for a trach and wake them up. Because I can turn the propofol off if that tube's not laying across the gag reflex, right? So I can trach them, turn off the propofol, wake them up, and then we find often they can come right off that tube because they're awake. This is why it's more challenging for our COPDers. So trachs are those type. The other thing I want you to be aware of is you should always check for when a trach was put in, particularly in ICU. And the reason is because a new trach that just got placed is slippery and the thing will slide out like that. You can be like turning a patient or doing some type of just normal care for the patient, and that trach will slip out. It's sutured in. They suture it in when they first put it in, but it's slippery. Just like a pierced ear. That's the best way I can describe it to people. Do you remember how, well, I don't know if you do, but do you remember how when people get their ears pierced, the first, few days or a week, if the earring comes out, what happens? So in the first 3 to 5 days after a trach is placed, they have the same problem. If that thing comes out, it's a medical emergency. It can be very difficult to get back in. This person may have to be intubated again. So we want to be real careful when a trach is brand new. So you should always, if you see a trach, check the chart. When was this trach placed? After it's been in a week or so, the epithelial cells heal around the circle, around the hole. And then if it's a long-term trach that's been in for a month, you can pop that thing in and out. They can take it out, put it back in. It's still there, just like your pierced ear. Does that make sense? So you should be aware to check the chart for when that trach was placed. Oh, I say beware of patients coughing. Why do I say that? Huh? They can dislodge it. That's a very good point. But that's actually more for you. I'm actually warning you. When you and I cough, if you look from the side, I'm coughing up, around, and out. It has to come, anything that I'm going to expel with a cough has got to come up and around a 90-degree curve to go out this way. So the velocity and the distance that it travels, that sputum, is only so far. When a trach patient coughs, it's down here and it's a straight shot. So when you see a trach patient getting ready to cough, move to the side. Get out of the line of fire, because you're going to get covered. You're going to get covered with whatever that person is there with, right? Whatever pneumonia or bacteria or whatever they've got going on in those lungs is coming right at you. And it shoots far. So that's more for beware of the patient coughing for your own protection. Two different things we can connect to trachs. And I wanted you to be aware of that. Do you know the tube that we put down? The intubation tube that we put down, and we said we connected it to a ventilator. A trach can actually connect to the same tubing on a vent directly to better control what we said to begin with. If I don't want any air from room air getting in, I can connect directly to that trach to control the total concentration of the oxygen going in. Okay? But after they've gotten better, or maybe it's someone going home on a trach and they don't need to have that high level of FiO2, I can use a trach mask. And the only way I can describe a trach mask is it kind of sits down below the trach, and I call it blow-by oxygen, because it just kind of blows at the opening of the hole. It doesn't fit tightly. It's not secured like an intubation tube would be to the tubing. So they'll get room air in that trach also. But as long as they're able to maintain their oxygen saturation level, then we're okay. So I got another critical thinking question for you. See how you handle this one. If I told you that as a nurse, you could only have one vital sign about your patient, just one, which one would you take? Why? SpO2? What about the heart rhythm? Don't you want your telemetry monitor? Which vital sign? Do you want a blood pressure? Do you want a heart rhythm? Do you want an SpO2? Do you want heart rate? Do you want a pulse? Which one do you think is the most important to have? She says that O2 sat. Why? That's a good answer. So excellent critical thinking. Excellent critical thinking. If your SpO2 is okay, is your heart working? If your SpO2 is okay, are your lungs working? Right? And it's actually circulating because it's getting all the way out to the end of the peripheral where you're checking it. So yes, even though that's not official, if as an ICU nurse, if I could have one vital sign, it would be SpO2, because it tells me the most about the status of my patient overall. I've had some people tell me rhythm. Why is a heart monitor rhythm not the most important? Doesn't that tell me that the heart is working? It doesn't even tell me if the heart's working. You can have a beautiful rhythm on the screen and the patient is dead in the bed. It's called pulseless electric activity. Remember that a rhythm is only testing the electrical signal that's being sent. It's not telling you anything about if the heart is responding to that electric signal. It doesn't tell you if the heart's doing this. And a lot of people confuse that, and certainly your patients' families will be confused by that. It does not tell you what the heart's actually doing. An echocardiogram can tell you what the heart is actually doing. They can actually witness the actual contraction of the heart. So a rhythm is not a solid vital sign because it doesn't really tell us if the patient is even alive, right? So you are correct. That was a good answer. SpO2 would be, in my opinion, the single most important vital sign. It tells you the most. Gives you the most bang for the buck, so to speak. Chest tube. So when I talk about chest tube, I know that it's probably a review for you guys, but I'm going to go over it because sometimes it can be murky, the whole idea. And you know this. Don't you love it when you watch like Grey's Anatomy or when ER was on and now it's Code Black? And actually Code Black's not too bad for, you know, they're usually pretty on, they're not showing you things that just aren't true. And you always see the monitor go flatline. And what do? Shock, clear, clear, shock. Do we shock asystole? The answer is no, we don't shock asystole. That's a total fib. They're lying to you on TV. We do not shock asystole, we give epinephrine. Okay? And then you also see this on TV all the time, all those TV shows. They're like, I can't breathe, I can't breathe. The person goes out, and they stick a needle between the second and third rib, and like magic, the patient goes, oh, I can breathe. Real or no real? It's real. That's a real one. Tried to trick you, but you guys are just too good. That is real. So let's talk about why that's real. This is a pleural space. It is enclosed. No air can get into my pleural space. Inside of my pleural space sits two balloons called lungs. If something pierces a lung to collapse it or just to poke a hole in it, I don't know, a rib cage during a car accident pokes a hole in a lung in one of those balloons, or a knife fight, or a utensil. You'd be surprised at how many things you see come in that pierce a lung. What happens is there's a hole in one of the balloons, and every time we take a breath, air goes into the balloon and out through the hole into the pleural space. This is enclosed. There's no place for that air to go. So the patient exhales, another breath. More air comes in, shoots through that little bitty hole into the pleural space, and slowly but surely the pressure in the pleural space around the balloons builds up so high that it collapses the balloons, collapses the lungs. So the idea of that having to put in a chest tube, that needle between the second and third rib, is to remove the air out of the pleural space so that the lungs can reinflate. We run that, we seal it up here, we have to allow it to drain. And how long do we allow this air to drain? Until the lung heals, until that balloon heals. So that means we have to figure out a way to run this, because now we have a hole here. That means air can get in from the outside. So to prevent that, because we need to allow a one-way valve from the pleural space to the outside. The way that we do that is by running it through a chest tube. And that's a water system which, based on different levels of water that fill up, creates a pressure. And it runs the air that comes out of here through a water system that prevents air, because air can't get through water, prevents air from going back in this way. Allows air out, doesn't allow air in. We're creating a one-way valve. This is just a one-way valve. Things that you should be aware of when someone has a chest tube. You need to always have a petroleum gauze at bedside. What is the petroleum gauze for? Yes, yes. If it comes out of the side right here, what are we trying? Why a petroleum gauze? Plug it. We've got to prevent the air from getting in from the outside into that pleural space, because the lungs will collapse again. So we want a petroleum gauze to cover it. The other thing that you have to be aware of is that chest tube itself, that system, the pressure system, needs to never be turned on its side. So we nurses in ICU, we will duct tape that feet to the floor. See the feet on this thing? We're going to duct tape the feet to the floor because, you know, our legs and our feet are going to kick that thing over and it's going to fall flat. It also disturbs the actual pressure because the water comes out. I mean, a lot of them don't even have, they usually do, but they don't always have a watertight seal on the top, so you never want to turn them over. They do come with a hanging device. So what is the hanging device? Are you getting a patient up that has this? Get them up. We have to wait for the lungs to heal. What's going to enhance healing? It can take a couple weeks for a lung to heal. Get them up. They can walk with a chest tube, i.e. the reason we have a hanging, so it can hang on an IV pole and stay upright. This is encouraged that they get up. It's like, get up, get moving. Okay, so here's a tough question. When do we know it's okay to take it out? It's a completely 100% educated guess. The pulmonologist goes, I think it's been long enough.
I guess it's also based on the type of injury they have. How big the
Depends on type of injury, how big a hole, but it's still just an educated guess. There's no diagnostic test that tells us 100% that the hole in the lung is closed. So we don't actually know. We can tell that the patient seems to be doing better, but that could be because the chest tube itself is working so well. So it still is an educated guess, unless it's some massive injury we can see on X-ray. But if it's that big, if it's big enough to see on X-ray, they probably need surgery. Yeah.
Is that a disposable system?
It is a disposable. Great question. It absolutely is a disposable system. We're not going to use it on any other patient because of the risk of something escaping or some infection that's going on. So no, we'll toss it and put a brand new one. Say I pulled it, the pulmonologist said, hey, this patient's lung is healed, pull it. And what if the lung collapses again? What happens? Same thing, needle in between the second and third rib, and we're back at square one. We'll wait another couple weeks. We already went over this. Single most important vital sign for any ICU nurse, because it tells you more overall about the status of the patient. SpO2, very important. Let me ask you a question though. If it's low, are you automatically assuming that the patient's tanking? It can be all kinds of things. Their hands could be cold. They may have very poor peripheral circulation because of diabetes. All kinds of things can affect the SpO2. So that shouldn't be the only clinical vital sign we look at just because it's low. What are some other things that would be an indicator that it was a low SpO2? Cyanosis, patient complaining of being short of breath. There's all kinds of other things that we could be assessing that would contribute to us saying that that is a valid SpO2. I'm going to talk about IVs now. Not just IVs. I'm going to talk about blood vessel access in general. So let's start at the beginning. What is a PIV? Peripheral IV. Peripheral what? And this is probably a good time to have the little talk about health speak, because we're all famous for doing it. Okay? You guys have gotten so good at knowing what PIV and PICC, what a PICC line is, and you've got all the buzzwords down pat. But guess who doesn't? Your patients. So I want to warn you, especially in ICU, because you will be so good at knowing what everything means and what they're talking about. But you also need to remember how to state it in layman's terms, because your patients need you to explain it. The doctor's not going to take the time to do it, I assure you. They have lots of patients. It's part of your job as a nurse to explain to these people who are in this. They're probably in some of the worst place that they've ever been. They're terrified and scared. They're family members in ICU, and they don't understand what's being said. They don't understand what you're doing or why. So you have to remember, even though we know what all the health speak is and we know what all those mean, we need to remember what they stand for and how to more easily explain it in layman's terms. It'll also make you a good teacher. to new students, right? So if you ever choose to go that route. So remember that. Don't just remember the words. Remember what they stand for. Don't just remember the acronyms. Remember what it means. One of the most embarrassing things that ever happened to me, I'm going to throw myself under the bus here, is I was giving this lecture about 3 years ago. And one of the students asked me what a PICC line was. And just to show you how we all do it, I went, for the life of me, I cannot remember what it stands for. And that's embarrassing because a patient could have just as easily been the one that asked me. And how embarrassing for me to say, well, I could tell him what the line did. I could tell him what it was for, but I could not remember what PICC stood for because we'd used PICC for so long that I just I didn't remember. So try to remember when we're using, a stat lock. How many of you know what that is? I guarantee you, a stat lock, your patients do not know what that means. They do not know. And I still remember a patient one time when someone came in as PT or OT and said, we need to ambulate the patient. And the patient promptly started yelling, why are you calling an ambulance? They didn't even know they don't know health speak. So what sounds completely benign to you and I sounds horrifically scary to a patient. So peripheral IV, that stands for yes, vein, remember vein. Because there's two types of access. We can be accessing veins or we can be accessing arteries. And those are very, very different things. So remember that. This is a vein that we're accessing. And what is this for? To administer medication, maybe to give maintenance fluids. Maybe we have it and we use it for drawing blood, although they don't recommend pulling out of a peripheral IV anymore. Evidence shows that it can actually blow the IV line. There's that pesky slide that threw me so badly. What does PICC stand for? I will tell you, I know now. I left immediately, looked it up because I was so embarrassed. So what does PICC line? We know what it is. What is a PICC line? It's peripherally inserted central catheter. Peripherally inserted central catheter. What's that? It can be peripheral or percutaneous, but it's the same thing. It means the same thing. And let me explain what it is. Who puts these in? If you've been at the hospital at all, you probably know.
Special nurse.
A specialized, it's not even a special nurse, but we like to say that. It's a nurse who's been specially trained, I like to say, because you could be a PICC nurse if you want. It doesn't require extra education as far as formal schooling. It does require going through a certification class at the hospital, whatever the hospital requires, and each hospital requires different. Some only require an internship with the PICC nurse. So it depends on, it's not necessarily anybody. Like I said, anybody could do it. So nurses put these in. Is this in a vein or an artery? It's a vein. That'd be a good thing to tell your patients. We insert it peripherally. It's got to be below the peripherals. And it runs up to the subclavian vein above the heart. It comes out at different places. So what's the difference between, have you ever seen a single lumen PICC? No. The evidence-based, most places won't do that. They're either dual, two, or triple. And the reason you will never see a single lumen PICC is because the protocol says in order to get an order for a PICC, you have to require a dual or triple. So if you don't require a dual or triple, they will sometimes still put a PICC in, like if it's because you can't get a peripheral IV, but they'll always put at least a dual in when they do it. Nobody puts in a single lumen PICC. It's usually here. Doesn't have to be, but it's usually here. it's a good place because it's out of the way, it won't get knocked. It keeps from being jerked and pulled. On the other side of it, after it's in, it goes here. The part that goes up here before the heart each port is open at a different place. Why is that so important? Why do we want them to not come out at the same place? Can you think of what a possible reason could be?
You mean like they're in a different, because you don't want to give medication if you give it through both mix?
Yes, because a PICC allows you, if you just put a dual port on an IV line, you can't run into medications that can't run together. They will crystallize in blood. They all empty into the same place in the bloodstream. You can't mix those. It doesn't matter that you put a dual port on it, it still goes into one place. But a PICC line they come out at different places, so each port is like a separate line so that you can run any kind of IV fluids that are not compatible with each other through each of the ports. So that's the advantage of a PICC. Obviously, all of those things apply. What about this one? Who puts this one in? Physician, usually surgeon. Is it a vein or an artery?
Venous, so it should be like.
It's vein. It's either jugular or subclavian, one of the two. So I have a patient that I know now needs more access. My IVs aren't going to work. I've got to hang 3 different meds at the same time. I call a doctor at 2 o'clock in the morning and I say, I need to get some kind of central line. Is the doctor more likely to order a PICC or a central venous line? Why? This is an easy answer. A PICC, because the doctor doesn't have to come put it in. It's always going to be a PICC first, because it means that you can call the PICC nurse and have them come put it in, and no surgeon has to come to bedside. This is a Mediport. A Mediport, vein, artery. I keep asking that, and you're like, why does she keep asking that? We'll get to it. Vein. Who has this? Who has this kind? I've heard these called Portacath, Mediport. There's all kinds of names for these. But there's one diagnosis that generally has these. Cancer. The reason is probably you can tell from the picture. It allows us not to have to stick them. All we have to hit is that bullseye and we're in a vein. That whole bullseye. Do you see it under the skin? I can hit anywhere in that and I'm automatically in a vein. I just have a little needle that just sits. This allows our cancer patients to heal up in between chemo treatments, and our skin is our best defense against infection. So a PICC line has 2 or 3 ports open that have a potential for infection. This allows the skin to heal up over top in between chemo treatments and prevents them from getting infection, in addition to not having to be stuck every time they need a chemo treatment. So that's the reason for them. We access it via a Hubbard needle. It's just actually a little needle that just sticks like at a 90-degree angle into that bullseye.
Who did you say you put those in?
That's put in by your dialysis doctors. That will be a nephrologist of some sort that puts those in. They're very protective of their blood vessels. They do not like people to mess with their blood vessels.
How long will it stay in?
They can stay in for months. As long as there's no sign of infection, they can stay in for months. They usually will leave them in until they quit working. And eventually, all dialysis ports stop working. As you get to the end of the diabetes diagnosis, you're getting more and more difficulty. That's why the nephrologist is so protective of blood vessels, because they know they're going to run out. And when they finally get to no more ports, there's nothing they can do. So they're going to be very careful with their ports. They don't want anyone to access these. And just to show you how protective they are, one of the worst times I had with the nephrologist is I got a patient report that a double amputee from dialysis, it was end-stage diabetic, coded at a dialysis center, was revived by the EMTs, coded again in our ER, and was again revived in the ER with epi, and sent, protocol says, you guys have had ACLS now, right? You've taken the code, you did the code blue this semester. ACLS says that if epi revives them, they stay on an epi drip. So she came to me 20 minutes after the last code on an epi drip. Guess where the epi drip was going in? Through her port, her dialysis port. I called the nephrologist to get an order to get a different kind of central line, and he screamed at me to pull the epi, to stop the epi. And I'm like, I can't get another IV. I ended up having to call the admitting doctor to come protect me. He was on his way up and was screaming at the top of his lungs. I'm like, I cannot pull it. I cannot pull it. I need another line. Can't stop. And of course the admitting doctor came and said, you can't dialyze a dead person. It's going to ruin my port. I'm not going to be able to die. You could have killed her. She's dead without the epi. So we have, and that happens. That's that turf war. But I understood the reason. He's trying to protect those blood vessels for this. Yes, but she's coded. Everything goes out the window when that happens. PCA pump. And you are used to this. You've seen these all over the place. I know you have. The only thing I'm going to ask you about these is be the good nurse that plugs them back in. In ICU, if you don't plug your IV machines back in, when you need to run to wherever you're going, to CT, to X-ray, interventional radiology, you're not going to have a battery, and you may have to wait and call Central Supply to get another pump. So please plug these things back in. Be the good nurse. But that's just my, pet peeve. Syringe pump works the exact same way as the bags that you see hanging. The only difference is I don't really ever see these. Never seen them. Adult ICU. Where do we see these? Pediatric ICU for sure. PCA pump. You will see these no matter where you work. At least if you work with any patient that, has pain. What are these? What's PCA? Here we go with the health speak again. Patient-controlled analgesia. So we need to make sure with these patients that A, family members aren't pushing the button, and B, remember that just because they push the button and they seem cognitive and aware to you laying down, standing up with a PCA pump can be quite frightening. All of a sudden they get dizzy and fall in a hurry, so you need to take precaution. Okay, so here we go with the ART line. This is an arterial line. How many of you have dealt with an arterial line? Maybe a little bit? Good. An ART line, what do we use it for? This is not in a vein. This is in an artery. So what do we have to, which would you be most concerned about? Duh, the artery. It's a high pressure system. If it comes loose, it's going to look like Friday the 13th in your patient's room. And it's going to look like Friday the 13th in a hurry. I have seen it come loose, and I've seen blood hit the ceiling, especially with a patient with a high blood pressure. And that's the reason we put an ART line in. One of the many reasons is that we're monitoring blood pressure, either low or too high, because it gives us real-time data. We need to know real-time if they're on a drip. We need to know real-time what is their pressure, not this isn't, we can't do that all the time. An ART line allows us to assess the actual blood pressure, the real blood pressure, all the time, every second. It just constantly monitors. So if they're on a drip for blood pressure or a lot of other things, we're going to monitor and want an ART line. But you do need to be aware, the higher the blood pressure, the farther that blood shoots if it comes loose. And I promise it will look like Friday the 13th in your room when it does come loose. So they can bleed out like that. It can be like, boom, done. So a patient on an art line, you need to be very aware that they have an art line. So I'm going to teach you a trick so that you're going to know if the patient has an art line before you ever step into the room. Would that be helpful? Just by seeing in the room. Ready? An art line, because it is so high pressure, has to have a pressure bag on the line itself going back, or blood would be shooting up into the tube. So even though this tube, IV tubing, I say IV, that's not IV tubing, it's art line tubing, but it looks a lot like IV tubing. So it looks like it, but there's a big, big difference. The art line has to have a pressure bag. It has to keep pressure, or blood would be shooting up every time the heart beat into that tube. So hanging on an IV pole is an IV bag that's in a pressure bag. It's ballooned. They're putting pressure on an IV bag to hold blood into that tubing. So you will know just by glancing in the room, art line, no art line, art line. That helps because you should be aware if they have an art line. That was one I'd be very careful of. I also always check the fittings. I put gloves on when I do my initial assessment and check the fittings because you want to make sure they're tight. They tend to loosen up over time. So you want to check those fittings and make sure they're tight. You're just going to go down the line, go and check, check, check. Oh, this one was a little loose, right? That way you don't have a catastrophe on your shift unless the patient pulls it out or it gets snagged in a bed rail. I've seen it happen. It happens. It's not pretty. So you want to be careful of it. The other thing you should know about an art line is there's a transducer. That's called a transducer. It's on the IV pole. That transducer should always be at the level of the heart. You know what happens when you raise the bed? The transducer needs to move. It doesn't have to be at every second, but it means that your reading on your blood pressure is inaccurate. So say I raised the bed because I needed to do something real quick. Well, if I wasn't worried about the blood pressure for the next 2 minutes, it's fine to raise the bed, do what I need to do, and then lower it back to where the transducer is. But that's how I'm going to check. I'm going to be like, is that transducer at his heart? Yep, that looks exactly right.
Let's just say you were doing something and then, it takes like 10, 15 minutes, but you're not monitoring, you don't care about, the monitor at that point. You can just leave it there and then, lever it down when you're done, right? Because the system is
Depends.
Does the system,
It depends on how fluid the situation is with your patient. Again, that's a nursing call. Can I wait? Is this patient been stable for the last 8 hours and now I'm doing a bath and going to raise him up real quick to wipe him down? Yeah, probably. If it's someone I've had to adjust the drip on the blood pressure med every 30 minutes for the last 4 hours, no, I'm probably going to make sure the transducer stays with the bed. That's a judgment call on your part. That's a very good question, by the way.
When I was in pediatric, I saw the transducers, and the nurse told me this is new because, like in the last year, the transducer had like a laser pointer light.
Yeah, we had them.
And then you turn it on, and
yes,
that's how you adjust.
Yes.
Pointing at
it has a laser, and I love those. I think that's much better because your visual can be so far off with evidence-based. So I have seen those, and I love that they have a laser so that you can see, is the transducer level with the heart? Because you can't trust the blood pressure reading or the readings at all on an art line unless the transducer is level with the heart. Look at where we can put them. Arm, radial, brachial, femoral. They can go at any place we can access an artery. Oh, and I did want to mention, even though I told you that the tubing itself looks a lot like IV, I want you to notice when you do your SIM, I want you to notice the difference between IV tubing versus art line tubing.
Probably thicker.
It's actually smaller and it's stiffer because it's thicker. That is correct. So the diameter is smaller and it's stiff. It's real stiff because it has to be, because of that pressure coming back on it. But do look at it and pay attention so that you'll know what the tubing, because Oh my gosh, do you know that's actually happened where a nurse connected regular IV tubing to an art line? It has happened. So you need to be able to tell the difference between art tubing, art line tubing, arterial tubing, and vein tubing for all of your peripheral, from subclavian, jugular, all of those are the same type of IV tubing, but you should be able to recognize the art line tubing and know what it looks and feels like and how it's different. It's not the same tubing. The other thing I want to point out to you before we move on, art lines have a stopcock. Do you know what a stopcock is? It's a three-way valve. So how do we tell which is open and which is closed? So here's my valve. It's in the line. This goes to the patient. This goes to the pressure bag. And this one is one that we maybe can do blood draws on. So it just stays like that, closed off. So if this is pointing at this one, that's what's off. That line is shut. That means this line is open. Can everybody see that? So where the yellow's pointing is where it's off. That implies that this way is open. This, I said, went to the patient. The bottom went to the patient. If I turn it like this, any concerns? I maybe turned it off so I can change the tubing out. We do that once every 24 hours on an art line. So maybe I have turned off to the patient temporarily while I replace this tubing. And then after I get new tubing, I go back to there. I've reopened it back up with fresh tubing. Okay? But what if I go, possibly I'm drawing blood. But what if I do that? Oh, very good. Do you see? So to the pressure bag is off. Any place that it's pointing is off. That means it's open to the patient and I have the cap off. He's gonna bleed out. I also wanted to point out, because this has been done, so I gotta mention it. This is a three-way valve too. I want you to see the difference. This is a type of three-way valve too. Can you tell me what the difference is between these two? Because I definitely want you to know the difference. I bet you she knows. This is for tube feed. Okay? That is wholly different than a stopcock for tubing, either art line or IV tubing. This can be used for either any kind of IV or it could be used on an art line. This is only for tube feed. This is called a Lopez valve. They are not the same thing. Does that help? So now you'll know when you see it, especially that orange. That'll be the dead giveaway that that's a tube feed. A tube feed. Okay. All I really want you to know about the EKG is that, because you guys are fairly familiar with them, we already talked about that you could have a perfectly beautiful rhythm and be dead in the bed. So we say in ICU, and I know you've heard this in nursing school because I know your faculty, we treat what, not what. What do we treat? We treat the patient, not the monitor. The monitor may or may not be accurate information about how your patient's doing. Holter monitor, I have never seen in ICU. This is something that they go home with because, and you know why, and it's because they'll say, I keep having these spells, but no, it hasn't happened the whole time I'm here. So we'll send them home with a Holter monitor so that when it happens, we can capture what's going on with the heart when it happens. You've seen telemetry monitors. These are the monitors that we can put in the gown pocket where it allows them to get up and walk away and not be hardwired in the room, like on a leash. So we like these. the telemetry monitors that we put in the pocket do not provide as nice a signal on the rhythms as the actual hard leash ones that go to the equipment themselves in the room. So this is only for people that are getting better and able to up and walk around, and we're not as worried. SCDs. SCDs, just please don't be that nurse that lets your patient get up and walks your patient to the bathroom with SCDs still on. I know you disconnected them, but they still will make your patient fall. So SCDs have to come off to get the patient to move at all. You need to take the SCDs off. The TED hose can stay on. We can leave the TED hose on because those are quite the booger to get on. So TED hose we can leave on, but SCDs need to come off and then put back on as soon as they lay down. Why are SCDs so important? And oh, here we go with the health speak. What do SCDs stand for? Yeah, it's there. Sequential compression. So why are SCDs so important? Let's talk about that for just a minute. Is a blood clot in your leg dangerous in your leg? Not in your leg, it's not. I was going to say, in your leg, your body actually will build another route around. It's in a vein. It's not in an artery. It's not dangerous at all while it's in your legs. It's just not. It's when it gets loose that it's a problem. It's going to go to one of three places. So what are the three places? Brain, heart, lungs. Brain, what happens if it goes to the brain? Stroke. What if it happens if it goes to the heart? Heart attack. What happens if it goes to the lungs? PE, pulmonary embolism. Okay, I'm going to give you a choice. Which do you want if you have to have one? I say none of the above. I'm not sure any of them are good. I mean, they are all horrifically bad. So my point being, you don't want a blood clot. There's not a good option with that. There's literally no good option for where it can go. Those traveling blood clots are often fatal. LVAD. Have you ever seen one of these? I treated a patient, had a couple of them with LVADs. What does LVAD stand for? It's right there. Left ventricular assist device. So I'm going to tell you a story. It's going to be a good story. It's going to warm your heart. I can tell you this because it was in the Dallas Morning News. There's a 34-year-old teacher here in the Metroplex. She's a mom with 2 kids, happily married, working as a school teacher. Her heart got sick. They don't know why. Sometimes hearts just get sick. She was healthy. She was completely 100% healthy one day and just started to get short of breath the next day. Before long, they realized that her heart was in horrific, horrific shape. And she ended up on the number 1 on the transplant list because the transplant list bases where you are on the list based on your ability for how long you could live with it. And obviously she's 34 and was absolutely healthy with no comorbidities prior to this. So she went immediately to the number 1 on the transplant list. The problem is she couldn't wait. There was no heart available and her heart was failing to where it was going to kill her. So UT Southwestern put in an LVAD. They had to make it special, not UT Southwestern, the manufacturer, because the ones that they had made in the past were for a man's chest, and it was too big to fit in a woman's chest. So the manufacturer had to design it specifically for her so that they could make it smaller and it could fit in her chest. So they did so, and they put it in so that she could live longer and hopefully get a transplant. She stayed on the number 1 on the transplant list. Do you think when they have an LVAD that they can be up doing much? Within 3 weeks, she was back teaching at school with her LVAD. Within 6 weeks, she was back at the gym with a battery pack on her back with her LVAD. It is amazing that it just takes kind of the workload off your heart to allow your heart to rest. It still provides blood flow to the heart, but it's actually doing the workhorse pump of the heart. They only last about 18 months before the bearings wear out. So she stayed on the transplant list. Every so often you have to re-qualify for the transplant list. They make you re-qualify to see if you're still in that position. So about 8 months after she got the LVAD, they called her in at UT Southwestern that she needed to re-qualify for the transplant list. That means they have to turn down, and they can do it remotely, but they turn the LVAD completely off and then requalify. We look at EF. EF stands for ejection fraction. And ejection fraction is the efficiency of how much your heart is putting out. Anything under 20% is frighteningly dangerous. You're on death's door. So they were checking her EF, turned the LVAD off, her heart had healed. They were able to take the LVAD out. Terrified her when they told her she no longer qualified for the transplant list. She actually cried. It took them a few minutes to convince her that that was actually a good thing, that she was actually recovered. I guess working out and being able to work out helped her heart heal. Well, it was sick to begin with some type of bacteria, you know, I mean, so it needed to rest and keep that blood flow glowing and maybe more time to heal. Shocking. I love these. Have you ever seen a patient? Have you been in ICU and seen a patient externally shocked? It ain't pretty. I'll just be honest with you. It ain't pretty. So there's 3 ways we can have a pacemaker in the heart. The first is when you collapse and drop and I have to throw pads on you and shock you 60 times a minute to keep your heart beating. Do you feel that? Yes, 60 times a minute. Feels like being kicked in the chest by a donkey is what the patients have told me. That's, of course, temporary. We are immediately taking you and trying to get a doctor, not a cardiologist, any doctor, ER doctor, to put in an internal pacer. They fish it in, and it goes in through the neck right here, subclavian, goes in through the subclavian artery. We fish it down to the heart, and they get it to where we're capturing, the rhythm is capturing, we're feeling a pulse with the rhythm on the monitor. As soon as we feel that, they leave the wires in, and that means that they do not feel it. You don't feel the shock when it's inside. You only felt it when it's on the pads on the outside. Then we can stop the pads on the outside. A cardiologist, specialist in cardiology, will put in a permanent pacemaker from that because we don't leave that, and that patient cannot move. We're moving that patient not at all because all you have to do is move those little wires that are coming out just a little bit, and we've lost it. So then we're going to be back to pacing from the outside. Not a good scenario. So as soon as possible, as soon as they can get a specialist in, the specialist is coming in and putting in a permanent pacemaker. I explain to patients, because remember how we just talked about we need to be able to health speak. I tell my patients, having a pacemaker is almost like walking around with a crash cart in your chest because it's a defibrillator. If their rhythm goes into something funky, it automatically shocks them. We get patients in from the ER all the time that come in because their pacemaker won't stop shocking them. Malfunction. It happens. So 3 different kinds. Notice I said obviously external, shocking them 60 times a minute from the outside. They're not going to be wanting to do anything. They're not going to be getting up. Internal pacing, same thing. We're not going to get them up until the permanent pacemaker is put in. All we have to do is just twist that wire a little bit and we're in trouble.
Would a life vest be considered external?
Yes. Excellent. That's an excellent question, and yes, it is considered an external pacing. It hurts. Then we have ICP monitor. What is ICP? There we go with the health speak again. Intracranial pressure. I want you to, in particular, to notice when we're monitoring ICP, the transducer that's on the IV pole again, just like on the ART line, it just looks a little different. It also usually has an actual bag to capture any drainage that comes out. What kind of drainage would we expect to see coming out of an ICP monitor? Any kind of drain? CSF, cerebral spinal fluid. Should be clear. Is it always? Have a little bit of blood, but we're concerned if there's blood. We're concerned if there's blood. We're concerned if it's off-colored. Usually implies there's infection. Yeah. Usually, just like your urine. If you see blood in the urine, what does that tell you? There's either a blood or it could just be a really severe UTI. So the same thing with cerebral spinal fluid. If you're seeing a lot of blood or some icky, funny off color and some blood, it usually implies that there's infection. The head of the bed. I said on the ART line it was the level of the bed. On ICP, it's the head of the bed. They must stay. It has to stay right. The transducer must stay. Maybe we'll have a laser for those too. I haven't seen that, admittedly. But it needs to stay with the level of where the patient is. So it's very important that you don't adjust the head of the bed. And people that are monitoring ICP cannot go below 30 degrees. Cannot be laid flat. Have you ever been over to Zale? Have you guys done any clinicals over at Zale? No patient in that entire neuro hospital will be below 30 degrees. If they're below 30 degrees, it's because there's a nurse standing next to them and they're doing something like changing them or changing the bed. They do not, that every patient has to be at 30 degrees. Why is that? That's a good test question. I'll do the Jeopardy sound. Do, 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 do. Could be drainage, but that's not really why. What are we monitoring? Pressure. What happens if I lower the head of the bed more than 30 degrees? Increase in ICP. That is correct, which is why every patient at Zale will be at 30 degrees on the head of the bed or higher. But 30 degrees is as far down as they want to go. This is the same thing, only it's a drain bag connected to it so that you can capture any drainage that's coming out. It's also used to alleviate pressure. But, you know, something that you should know right off the bat, there's only so much pressure they can release. I mean, once all the cerebral spinal fluid is out of that space, there's nothing more they can do to release the pressure. These are all the drains. I'll go through these really quick and you can look through them on your slides. So let's talk about drains and just some things that we should be aware of. We have Jackson Pratt, we have a Penrose drain. Some things you should be aware of. The bulb should always be collapsed. If it's not collapsed, it's because it's full. So we need to empty it and because it creates a suction. We want that suction on all wounds, no matter what kind of wound it is. Why? Yeah, because evidence base shows that wounds do tremendously better if we're constantly suctioning out the pus that can collect. So we want always there to be suction on wounds when they have a drain. And I love these. I know you've seen them. One of the coolest ones I saw is the vacuum-assisted devices for wounds. They look like they're an alien, you know, like they attach some alien being to a wound and they're sucking on them like... they look so cool. That's a specialty called an ET nurse that puts those on usually, or a doctor. And their evidence base shows that they work fabulously because they're constantly sucking the pus out of the wound. The cleaner we keep the wound, the faster the healing time on the wound, so they're imperative. I always warn you, if you have a patient with one of these Penrose or the Jackson Pratt wounds, when you first get them up because they've been sitting for a while and they suddenly want to go back to bed, and you get them up to help them get back in bed, and all of a sudden, what are you seeing coming into the collection device? All of a sudden, there's this massive amount of pus that comes out. Why? Because it pulled up inside their wound, and when they moved, it shifted, and now it's all coming out. So it isn't that they all of a sudden have a lot of pus just all of a sudden. It's more likely that it was pulling up inside. But it also tells us that the drain itself isn't working as well as we would like it to, because we really want the pus to be extracted from there all the time so that it doesn't pull up. Because what happens when pus pulls up inside a wound? More infection. Yeah. Okay, so here's the next, there's the Jackson Pratt. See this one over here on the far side, on that side. Is that one a good one that you would just leave your patient with? No, that's full. That's not creating a suction. That needs to look like this one over here, although we do not wait till it gets to here to empty. This right here is where you need to empty and measure the output, and then you need to chart it. They need to be down here at all the time. So, and how often do we have to change these? How often are we having to drain them? And depends on how much they're putting out. You might be doing it every 15 minutes, or you might be doing it once a shift. There's a pigtail. Same idea. There's just different types of drains, but they all work the exact same way. There's that alien. There's the vacuum-assisted device that looks like an alien. It looks terrible. It looks like it hurts, but it's real flexible, and the patients really don't mind it. NG tube. We have an NG tube. What did I say this was? Lopez valve. This is what we're going to want to do tube feed. Not this. What's this one? Yeah, what's it for? Art line, IV line, whatever you want to use it. But remember, for NG tubes, we have two things we're doing with an NG tube. One would be to suction or decompress the stomach. The second thing would be to actually provide tube feed, nutrition for your patient through your NG tube. If a patient is getting nutrition, we do not, again, the head of the bed, just like on the neuro patient, must stay at 30 degrees. Why? Even temporarily. We do not lower the bed beyond 30 degrees for anybody that has continuous tube feed running. Aspiration. That is the correct answer. Very good, guys. Aspiration. So if we're going to lay the patient down, we're going to stop the tube feed, lay the patient down, do what we need to do, put him back up to 30 degrees, and then restart the tube feed. These they come, the names of them are all related to where they're positioned on the intestine. They can be the stomach, they can be a jejunum tube, they have them everywhere on the intestine line. So the name just implies where they're put in. We don't have to worry about aspiration with these because they're not going through this way, they're going directly in. So these we do not have to worry. So if they have these going with any kind of a continuous feed, we don't have to worry about them. However, we generally don't see these with continuous feed. We usually, by the time they get these, we do it 3 times a day, sometimes 4. We just inject the tube feed like a meal. Does that make more sense? All tube feed runs through, and I don't know if this is true or not. I have no idea, but I have never seen anything used for nutrition and tube feed other than a kangaroo pump. Have you, ladies? Is there any kind of other pump used?
No, I think they're all called kangaroo, but I've seen older ones.
But they're still the same brand. I mean, Kangaroo has got the market cornered on nutrition. They all have a little kangaroo on them, and it's one manufacturer. So if you see those kangaroo pumps, those are for nutrition. Foley catheters. You guys know about these. We do not want to pull it out. You know there's a balloon inflated at the end because you've already been trained and you have checked off. So you know why we do not want patients pulling them out and why we don't want them to accidentally get jerked out. Particularly if it's a man. It's a urinary consult. Okay? It just is. But it also can be for women. So we need to make really, really sure that we're not hanging it on the bed rail. We need to make really, really sure that it's not being pinched between the rail as it goes up and down. And also when the patient's moving, that they're not stepping on the tubing and jerking it out. Why do we have to keep the Foley bag below the bladder level? Yeah, because you're automatically causing an infection if you go above. The only thing I'm going to tell you about ostomies, because you've already been checked off on them, and sometimes when I do this lecture, they don't even know what an ostomy is. I know that you guys do. So all I'm going to do, and I know that they've already warned you, I'm just going to reiterate what you've already been told. This is the review part that I warned you about. You need to learn to guard your facial expression. These ostomies smell horrifically bad, and they produce a tremendous amount of methane gas that smells to high heaven. These people are aware that they smell. You've got to guard your facial expression so that you don't further traumatize them about how they smell. Also, before you get them up to do any kind of ambulation, empty the bag. That's for your benefit and theirs. There's the bladder. These don't smell as bad. Because it's coming from urine, you hear on all those shows, you can drink your urine, it's sterile, whatever. Only if I'm stranded up in a mountain. But they don't smell as bad as one that comes from the intestines, obviously. But you still, again, empty it before you ambulate, or it would be for your benefit and theirs, because that liquid's very heavy on the bag. Physics tells you that that bag is much more apt to open with all that weight. And it will be when you're out in the middle of the hallway. Ostomies into the kidney, they're very similar to the bladder ostomies. So you're going to handle them the same way. Empty the bag before you ambulate. They won't smell like the intestinal ostomies do. Report any leakage, and please don't jank them out. You know, make sure they're not being pinched or pulled. Restraints. I know they're telling us to get the restraints out, but ICU is the one place where restraints, you're more apt to run into patients with restraints, and it's for the right reasons. What do we talk about with the endotracheal tube? That tube that goes down? If they wake up, what are they going to do? Yeah! And it's laying across their gag reflex. I'd pull it too. So there's a reason to use restraints. It's to protect the patient sometimes from themselves. Even if it's like you or I that were completely cognitively aware, we don't want that thing laying on our gag reflex. So restraints are used appropriately in the ICU setting and in some other settings as well. But we do need to make sure that they're not tied to the bed rail, that we're using them appropriately, and that we're using the least restrictive that is necessary to accomplish our objective. Meaning if I have the little old lady, which we've all had, that's picking, we call them the pickers, where they're picking at tubes. They want to pinch tubes. Pick, pick, pick. You know, these are great for them. It allows them to still be able to move and maybe itch without having their wrist tied down. Do you see what I'm saying? So think about what's the least, because generally it's not the doctor that's asking what level of restraint you need. It's you asking what level of restraint you need. It's you saying, hey, I really need to put this patient in some mittens. They're just pinching and pulling at tubes and lines. So there's the ones I know you've seen. We don't like doing restraints. Restraints create a tremendous amount of more work for us. We have to document circulation. We have to check circulation. We have to document, get orders every 24 hours to renew the order. They're obviously a lot more work. So we only use restraints when we absolutely have to. But you will find in ICU that tends to be often. Traction, the only thing I would warn you about traction in case you haven't seen it, is traction is when an orthopod has put weight on a patient to try to offset the pressure. And so there's literally weights hanging off the end of the bed. So you go to move the patient over to a stretcher because you're going to CT. Don't lift the weights. You've just ruined the pressure that they're trying to create. You want to kind of just keep them from swinging too much as they're moving the patient. So your job is to kind of hold them like this without taking the weight off. So it can be tricky. Can be very tricky. So that's all I wanted to warn you about on traction. I love these things. They look like Frankenstein. The halo devices kind of looks like Frankenstein-y, doesn't it? Although I used a kid to make it look less, a little bit more nice, a little more friendly. This is a big fall risk if you have these as patients. These patients are usually up and moving, but you need to be aware that they've lost their peripheral vision. So there's two things that happen. Number one, they can't, you know how people get older? They sometimes have to see where they're going in order to walk without falling. This prevents them from looking down to see where they're going. So they can't see stairs coming or how far they know they're coming, but they don't know how far away they are. Also, they'll run into things from the side. They'll bang because they don't have peripheral vision. So just keep that in mind. And I only went 5 minutes over. 5. That is it. That covers a lot of information. So did I tell you all the truth? I said, I'm going to review a lot of stuff that you probably already knew, but I promise you're going to hear something you didn't know. Did I accomplish that? Yay! The one thing I didn't tell you about monitors, because we kind of skipped past it, that I kind of wanted you to know. Have they taught you about the sounds of the monitor and what it means when it makes the sounds? So the next time you go to the hospital, if you hear this, boop, 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 that is the monitor patient saying, help me, help me, help me. That means their SpO2's come off, a lead is popped off, an electrode, something is minorly wrong. But if you hear beep, 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 that is the monitor saying, I am dead, I am dead, I am dead. So when you hear that triple beep, watch all the nurses turn and look at the monitor, because they all are attuned to hearing that triple beep and looking to see, uh-oh, what's wrong? What's that rhythm? Why is it making that sound? Okay? Just a trick. We all get used to the sounds that we hear when we work. Women's health nurses listen for fetal heart rate up and down. I mean, they can tell by just listening to the sound whether a fetus is in trouble or not. Well, ICU, we get used to the sounds of some minor trouble, or I better turn around and look at the monitor because someone could be dead. Any questions before we move on to the simulation? Okay, so what we're going to do for simulation, I hope you learned something. I think you probably did. Might be useless information, but you at least learned something. But I'm betting you learned some pretty useful information. So before we move on to my simulation, I want you to tell you what you're going to do. You're going to work in pairs, okay? You're going to go in and to a room that I have set up where I was the last shift nurse. You're going to quickly determine that I was not a very good nurse. The room is a mess. It's an absolute atrocious mess. I want you to find everything that's wrong in the room. I want you to tell me what's wrong. I want you to tell me whether you consider what's wrong to be critical, major, or minor. And then I need you to tell me what interventions. How are you going to fix it? Obviously, when you prioritize, the critical should be fixed first, right? The major second, and the minor third. And whoever finds, they're going to award points for what you find. And whoever top 3 people that find the most wrong, there's prizes. They may be sugar related. So if you're diabetic, you may have to decline. Yes. Go take a break. And I'll meet you over at 4620. 10 minutes. Ms. Sorotis, how do I stop this integrity?
Thank you.
Did you enjoy it?
Yeah, that was great.
Very good. You never know.